while some more people sign on. I'll put on the agenda so you can take a look at that while we're while you're sitting here. So a few housekeeping things while oh, thank you. I see people are saying we can see you. Thank you. Because I can't see anyone, and I guess you can see me, but the way the webinar set up is you're all muted and I can't see anyone. So I'm Valerie Bogart. I'm director of the Evelyn Frank program at NYLAG. And I want to thank Suffolk County for the Aging's HICAP program for having the idea of doing this today. They said, we need information about what's happening. And I thought, you know, we really need to do a public webinar and reach out to all of our colleagues and to share what we know so far about what's happening. And you'll see that we know some, but there's a lot we don't know. So just a few housekeeping things. On the Go to Webinar tab, you'll see there's a little thing to click on for handouts. So there you can download the agenda, you can download the PowerPoint as a PDF, and you can download some materials that I put together, some links, helpful links, resources. So that's a resource for everyone. Another housekeeping matter is if you are seeking CLE. At 2 points during the program, I will announce a code, and it will be on the screen as well. So at that point, make a note of the code, and after the program, you will receive an email from NYLAG's pro bono coordinator, Valentina, that will have an office form for you to fill out online, and that will ask for the codes. And that from that, you will get your, show you that you were here, and you will receive your CLE certificate. One more housekeeping matter is that there's an option here to put in questions and also to use chat. We're suggesting you use the question because then the answers can actually be lined up with the question instead of like a million comments later. And we will be able to download all these and follow up. Peter Trevitsky and Rebecca Wallach will be monitoring that and answering the questions as they can, and also identifying questions that would be helpful for us to answer later or discuss later in the Q&A. So with that, we have 245 people so far. We have over 350 people signed up for this today, which is sort of tells you how much this information is needed. So giving you the outline for the day, let's see, there's one other thing I could do here. First, we're going to just briefly discuss some COVID changes, issues. We can't talk about Medicaid without giving you a little bit about the governor's budget proposal to increase the Medicaid limits, and then we'll get into the meat of the program, which is the independent assessor that's supposed to start March 1st, and then a bunch of other home care changes. So there's a lot to cover. Let's see. Just a word about NYLAG for those of you who don't know us. We are a large nonprofit legal service organization, and the Evelyn Frank program is one of, God, what is it, at least 20 units in NYLAG, and we specialize in Medicaid and Medicare. But we have lots of other units. Check out our website. the Evelyn Frank program is part of the ICANN program, and there are slides at the end about ICANN. It is a statewide ombuds program, and if you don't know about it, it's a great resource and a place to refer clients. We are not charging for CLE credits, but we do suggest a donation if you are requesting CLE credit or if you're moved to do so otherwise, and this slide tells you how to do it. It will be there when you download the slide. We thank you for your support. So first, starting with COVID issues. Most of you probably know that there is a chronic aid shortage as well as a nursing shortage. And that's been true before COVID, but it has been exacerbated by COVID. There is a bill, the Fair Pay for Home Care bill, that would, excuse me, that would probably really help the situation. It would increase wages to 150% of the minimum wage by region. And unfortunately, the governor did not put this bill into her budget. Instead, the budget includes a one-time bonus to be given to all direct healthcare workers. That's nurses, aides, nursing home staff. And I don't have all the details of it, but a one-time bonus is not going to do enough to solve this problem. Just a practical suggestion, if it's an MLTC case, file a complaint with the plan, a grievance with the plan, file a complaint with the state. Your legal argument is that plans have to have capacity. They have to have network capacity. And if that means using an out-of-network provider, then that's what they have to do. And those sites are in the footnote on the slide. But of course, the shortage is so bad that even if they go out of network, they really might not be able to staff a case. And excuse me. And another advocacy tip that some of our colleagues have done is ask the client, ask a social worker, many of you are social workers, get on the phone and find a vendor, a home care agency that will do the job, and present that to the plan and say, look, I've identified 3 home care agencies. 1 is in your network, 2 are not. They say they can staff this case, and put that in writing. And then that will really strengthen your complaint or strengthen your case at a fair hearing. Speaking of fair hearings, those are very delayed in scheduling, also because of the pandemic. So the state is saying because of the pandemic, they don't have to schedule and decide hearings within the usual 90-day time limit that's normally required by federal regulations. So they're prioritizing cases that don't have aid continuing. Now, there's one type of case which they are giving a sort of aid continuing to, and that's cases that affect most of our clients. Many of our clients are seeking an increase in home care. And when you request a fair hearing to appeal a denial of an increase, 45 days after you request that hearing, if the client is considered homebound, which simply means that they would have a difficult time traveling to a hearing, the state will order something called an interim Varshavsky increase. And what that does is orders the plan to increase the home care to the amount requested. So basically, you're getting what the very thing the fair hearing is requested for. You're getting it temporarily until the state holds and decides the hearing. And that hearing includes a home hearing if the client doesn't win the first hearing on the phone. So with even phone hearings being so delayed, home hearings will not be, we don't think, scheduled for well over a year. There's such a backlog. So if you can win your client an increase that will last at least a year or more, that's a huge win. So the state is considering those Warshawski increases to be a continuing, so all those hearings are on hold. They don't have priority. But warning, there is one type of MLTC plan that doesn't get this special Warshawski increase in a fair hearing, and those are the Medicaid Advantage Plus plans, or sometimes abbreviated as MAP plans. And they are increasingly covering more people. They now have 30,000 MLTC members are in that type of plan. Now that's compared to 250,000 in a traditional MLTC plan. And the difference is that the MAP plans are an all-in-one plan that includes a Medicare Advantage plan as part of the plan. So they cover all Medicare and Medicaid services. So the fair hearings for those plans are a new procedure called a FIDE hearing. They're also run by OTDA, the state hearing office. They don't have the Warshawski increases. Now, there's a whole article on those hearings here. There's a whole article on the Warshawski increases here. So I urge you to look at those for more information. Now, another COVID issue is people trying to get into MLTC. There are huge delays in scheduling conflict-free assessments. We typically hear that someone calls now and it's scheduled 2 months down the road. We urge people to file complaints with the DOH MLTC complaint unit. Those contacts are at the end of the materials, and they're also on the handout, resource handout, to complain about these delays. And not only is it make it difficult to get into MLTC, but in a minute we will talk about the independent assessor. And it's the same company, New York Medicaid Choice, that will be conducting hundreds of thousands of assessments under independent assessor. So the state needs to hear those complaints so they know that there are capacity problems with the independent assessor. If you do file a complaint, the complaint unit at the State Department of Health will tell you, go apply for immediate need at your local DSS. So we recommend that, apply for immediate need. Now, they also have aid shortage problems, terrible problems, even in the city. And before COVID, we really didn't see aid shortage problems in the city, but we're seeing it in a big way now. But it's a system we have, and you have to try to make it work. Another COVID issue is, this is a good issue that's helped our clients. Since March 2020, Medicaid is extended automatically for a year without sending in that Medicaid renewal or recertification. And what's confusing is that the city, HRA, still sends out those renewals. So people think they have to send them in, but in fact, they have not been required to send them in. I've heard other counties don't even send them out. And this is all because of the public health emergency that threw tons of money at states for Medicaid. And in return, states are not allowed to cut off anyone's Medicaid or even reduce anyone's Medicaid. So that means increasing their spend down. Now, we do see problems with this. We still see discontinuances creeping in. And if you get those, request a hearing. You can contact, if you're in the city, you can contact our FLRP intake about those, and we can troubleshoot those. Our intake information is at the end. But this will probably end this year. We just have to stay tuned. The public health emergency was just extended till April, but it might not be extended again. And when it ends, the renewals will start again and they will matter. And so that means helping clients get their ducks in a row. Their income has gone up. That means they have to increase their pooled trust contribution and make any other changes, so that by the time they have that renewal, they can report an increased pooled trust contribution or anything else. If they happen to get some assets like an inheritance during COVID, they can report it's gone, when it was gone, show that their resources are down to the resource limit, all of that. So that's our job as advocates. Now, related to this is Governor Hochul's proposal to expand Medicaid for people age 65 and over, disabled and blind. If you want to see the amendments for yourself, take a look at the budget, and it's all there in Part N of the Health and Mental Hygiene Bill. It's sort of exciting to see it in writing and see all of these deletions. So the first change is increasing the income limit from the current limits to 138% of the federal poverty line. So it would borrow the same limits that apply to MAGI. MAGI is the type of Medicaid received by people under 65 who are not on Medicare under the Affordable Care Act. And mostly they get it on New York State of Health, the state's marketplace. Now, a lot of people get confused by this. They think that now everybody will be MAGI, and that's not the case. As I understand it, the age-blinded disabled group, sometimes we call them DAB or ABD, will still be non-MAGI. They will still have all the budgeting rules that they have now. The $20 disregard, the way household sizes is calculated, and spend down. If their income is over the new limit, they'll be able to spend down to the new limit. But now they won't have to spend down as much, right? Because the income limit is going up. And by the same token, they'll still be able to use a pooled income trust. This is my view, right? None of this is spelled out in the law, but this is my interpretation, that it doesn't change the rules. It only changes the income limit. So they won't have to put as much in a pooled income trust, and many people will not have to use a trust at all. And we'll show you the income limits on the next slide. Now, the really nice thing is, over the 2 years of COVID, anyone who was on the marketplace with MAGI Medicaid was allowed to keep their full Medicaid and not switch to non-MAGI Medicaid. They've just been sort of frozen there. And I heard that there's something like 100,000, maybe even more, between 100,000 and 200,000 people in this situation who aged into Medicare over these 2 years, or got Medicare because of being 2 years on Social Security disability. So if the timing is right, with the end of the public health emergency, when these people now go through renewal later these changes don't go into effect till January 2023. So I'm hoping the state will defer their renewals till then, and then reassess them under these new limits so that they can keep Medicaid and not have to be switched to spend down. So that would be nice. Nursing home budgeting would not change at all. All your income would still go to the nursing home. You keep a small personal needs allowance, and the spousal impoverishment rules for income would remain as they are. This is how I understand it, okay? So let's look at the income limits. We know for a single person, it went up to $934 this year. And the federal poverty levels for 2022 were just announced. The state hasn't yet issued its new charts, but we did the math, and it goes up to 1563, which is a 64% increase. So we think a lot of people will not have to use a pool trust anymore, will not have to spend down. Now, there are still plenty of people with pool trusts with incomes above that who will still need them. And the couple limit also goes up. So this would be amazing. The second part of the change is the elimination of the asset test. Now, all of this has to be approved by CMS. And this way, the non-MAGI asset rules would be the same as the MAGI asset rules. They simply wouldn't count. And as I understand it, this would be for nursing home Medicaid and community Medicaid. So we would still have spousal refusal, but we wouldn't need it for assets. In fact, they took out the word assets in the spousal refusal statute, and it only says income. So do not know how the look back will work for nursing home care or for the community-based services that we know is planned. And I have no update on that. We still don't know when the look back will start, and we certainly don't know how it will work if there is no asset test. So I can't answer questions about that because I just don't know. We do know that if you have MAGI Medicaid and you need nursing home care, there is a look back and transfer penalty, and that guidance is on your slide. You can look at the federal guidance and you can look at the state guidance. So we know that there could be a look back and transfer penalty even without an asset test. We just don't know how it would work. And why are they doing these things? This whole thing is about racial equity. Sorry about this glitch here. The asset rules are really biased against people of color. The asset rules, as we know, have some very generous exemptions. All IRAs are exempt as long as they're in payout status. But statistically, who has IRAs? White people are statistically much more likely to have had jobs, white-collar jobs, where they have the opportunity to save in retirement funds and in IRAs. So those are exempt. But if someone saves cash, it's not exempt. The same thing with the home. The New York Times ran a big series last summer, about how there is still abysmally low home ownership in New York City, New York State, by people of color. And yet a home is exempt, over $950,000 in equity. But you have $50,000 in the bank and it's not exempt. So that keeps people away from Medicaid who truly need. These Medicaid changes are supposed to go into effect January 1st of next year. Honestly, that seems like a very fast pace, considering they have to submit a lot of stuff for approval to CMS in that time, and they have to do huge systems changes to make that happen. So it seems very ambitious to get that done that quickly. So I would be surprised if it happens that quickly. If state recovery doesn't change, so let's say someone in theory could have 3 homes and get Medicaid. If they die with those homes in their name, Medicaid will still do estate recovery. Okay, so elder law attorneys will still be busy with that, but they will have less to do to make people eligible for Medicaid. So since this doesn't go into effect till next year, new applicants now still have to, follow the same rules. They have to have spend down, bring their assets down, everything else. So, and then we already talked about the renewals. All right, so now we're going to get into the independent assessor. If you are a wonk and want to look at the actual regulations that were adopted effective November 8th, you can find them here. Part of them is already in effect, and part of them is supposed to start March 1st, and some of them is supposed to start later, and we will talk about each of those things. NYLAG and the State Bar Association and Legal Aid and many organizations commented on these proposed regulations, which are horrible. Well, it's not all horrible, but they didn't really listen to us very much. So the first thing we'll be talking about is the independent assessor. To get a sense of what this is, we already have part of the independent assessor, and that's the conflict-free assessment that's done by Maximus or New York Medicaid Choice. So as if you do MLTC, New York Medicaid Choice, the consumer calls them, they send a nurse, or they call the client through telehealth to do a thorough assessment with the UAS tool. So that is what the independent assessment is, the first part of it. It's by New York Medicaid Choice, it can be by telehealth, it's a nursing assessment. But now, instead of it only be your gateway to MLTC, it will replace the nurse assessment that is normally also done by your local Medicaid office, if you're applying for personal care or CDPAP there, or the plan. The plan will no longer do a separate assessment for a new enrollee. It will only use the independent assessment. So, but that's not it. That's only part of the independent assessor. Once that is done, New York Medicaid Choice will hand off the case to an independent practitioner panel, which you'll see IPP in here. That is an exam by a physician, a physician's assistant, or nurse practitioner who also contracts with New York Medicaid Choice. And they will do an exam, which can also be by telehealth, and they'll prepare a practitioner's order. So in New York City, we know that is the M11Q. The rest of the state uses this form 4359, and that's what we understand is the form they'll be using. So if in situations where before you had the client's doctor fill out that order, an M11Q or this statewide form, no more. The client's doctor will never fill out a form again. It will be done by this New York Medicaid Choice contractor who doesn't know the client. So these two parts they're calling the independent assessor. They go hand in hand. It's always going to be the nurse and the IPP. Now, what they've said, and none of this is in writing, okay, is that if someone's trying to get into an MLTC plan, we said, well, do you need both of these to decide if you've tripped that floor? Are you eligible to enroll in an MLTC plan? They've said no, that will still be only the nurse that can decide that. That will give you the thumbs up to contact a plan and enroll in a plan. But that's not in writing, so we don't know if that will also require the IPP. So just to clarify, when are these two new assessments needed? For enrollment into MLTC, replacing the conflict-free, for all immediate need applications, so you'll no longer submit an M11Q and physician's order. I don't know exactly how you'll file the request without those forms, but you will somehow file a request, and the DSS will refer it to Maximus to do these assessments. And any other request to your local district where the client is allowed to apply to the local district instead of to an MLTC, such as if the client gets home hospice or is an OPWDD. Then we have the annual reassessments. So the law switched these from being every 6 months to once a year. And so that's good, but it's still right there. That's 280,000 new assessments a year that New York Medicaid Choice is doing. And it's not just the nurse assessment, it's the nurse and that independent practitioner panel. And then every time you request an increase from an MLTC plan or a managed care plan. Oh, I forgot to include that. It's all mainstream managed care also. If you request home care from them, they have to send it over to New York Medicaid Choice for these assessments. And every time you are discharged from a nursing home or hospital, the regulations say now they must do a reassessment. Before, it was the discretionary for them. So this is a huge new lift for Maximus that they think is starting March 1st. Now, that's not all right? Let's say those two assessments are done. What's next? Those assessments don't decide how much care somebody will get. Those decisions are still made by the DSS or the plan. So they take those two assessments and develop a plan of care. In other words, deciding how many hours the client will get. If they can also dispute those assessments, if they have a material disagreement that affects the plan of care, because don't forget, the plans are used and the DSSs are used to their own nurses doing these assessments. So now it's going to be this contractor from Maximus, New York Medicaid Choice. So they have built into this process a chance for the plan or DSS to disagree and say, wait a minute, this person doesn't need to be turned in position. This person doesn't have total assistance needs for toileting. And if that materially affects their plan of care, they can throw this into a huge delay and make the Maximus do a new assessment for which they have 10 days. Delay, delay, delay. Now, will the plan or the DSS still have a nurse assess the client? This is not known. The state has acknowledged that they will have to do some sort of assessment to fill in gaps in the New York Medicaid Choice assessments because the UAS assessment tool has gaps. It doesn't ask, what are the client's nighttime needs? And it only asks, yes or no, are there informal caregivers involved? It doesn't ask, how extensive are nighttime needs? Now, how could a plan ever distinguish between live-in or split shift if they don't know the extent of nighttime needs? That's what the difference is about, the frequency of need. How could they know what the caregiver support is unless it's asked very specifically, what time is the daughter coming home from work? What time is she willing to take on taking care of mom? Now, we know the plans and the DSS don't do a good job of this anyway. But part of the fault of that is that it's not in the form. It just doesn't ask the question. So this is a big gray area. In MLTC enrollments, we don't know if the plan will still come and do an assessment visit because they're no longer doing the assessment. Now, so if they authorize 12 or under hours a day, just correct that on your slide. It should be 12 or under, up to 12 hours a day. They do their plan of care. They send a notice saying, okay, we're giving you, 8 hours a day, 5 days a week. And then it's the usual process of appeal. But if they decide the client needs more than 12 hours a day, then we go to the next level of review, which is the independent review panel. And this is run by, guess who? New York Medicaid Choice. And it's another panel of, I forget what the reg says. I assume there's a doctor in there, but nurse practitioner. It's supposed to be independent, but they work for the contractor of the state. And they review a proposed plan of care of, say, 24 hours a day to see if it's reasonable and appropriate to maintain the health and safety at home. Now, but they don't make the final decision. So even if they say it's perfectly safe, it doesn't mean that the plan will necessarily authorize it. Although if it's the plan that has sent New York Medicaid Choice, we think this person needs 24/7. So they've basically committed to authorizing it. So it's really unclear what the whole purpose of this assessment is. It does raise alarm bells to disability advocates anytime you have a doctor or a nurse or any sort of decision making judging whether a plan of care maintains your health and safety, because it brings in a lot of stereotypes and assumptions about what is safety. They've tied the hands of this review panel and saying they cannot recommend a specific amount of hours. So to me, since the panel will only get cases where even the plan and DSS say this person needs more than 12 hours a day. Now in New York City, that means 24 hours a day. I think there are some counties where your DSS might say have plans of 16 hours a day. But so let's say the plan says, okay, we think this is a live-in case. The IRP may recommend changes in the plan of care, but not specific amount of hours. So is this IRP allowed to say, no, this is a split shift case? It looks like the state's trying to say they're not allowed to say that by saying they can't recommend amount of hours. So what's the point if they can't? Now there's also a question of who is grandfathered in. Do people now getting live-in or split shift care have to go through this process? The regulation is ambiguous, and it suggests that they do. The regulation, actual words suggest that they do have to go through it one time, and then if they get through it and are authorized for 24-hour care, that in future renewals, they won't have to go through it again. At a meeting, a state administrator said, that wasn't our intent. We want to grandfather in anyone who's getting 24-hour care. So we said, well, you need to clarify that because that's not how you wrote your regulation. And I know I have clients who now get split shift who've gotten it for many years who are nervous about this, someone judging whether that plan of care maintains their safety at home. So once they get that, then the plan and the DSS make a final decision. and they don't have to take the IRP recommendation. So why is the state throwing all this money at this new assessment if it can't recommend a change in hours? And the big criticism we put in our comments is if let's say the consumer asked for 24-hour split shift, but the plan said live-in. The plan only has to tell the IRP, we're recommending live-in. They don't have to say, but the consumer has requested split shift. So the IRP could say, well, the live-in plan that won't maintain health and safety at home. But they can't say, but the plan requested by the consumer will, because they won't have that plan and they're not allowed to recommend a specific amount of hours. So, the whole thing is set up in a way not to really decide what's a safe plan of care. So after all that, you get your notice. So this is the scheme that the state created early on to describe this whole phase. So just to review, the independent assessor, this is the nurse assessment. They call it a CHA, community health assessment. It's the same as a UAS. It's the nursing assessment. And they will decide for someone who's seeking MLTC if they qualify for MLTC. This slide also says, do they meet the new ADL criteria? Those criteria are not yet in effect, okay? So then it goes to that IPP, the independent practitioner panel, and then the plan, the managed care organization or DSS, then develop a plan of care and authorize services, except if they are authorizing more than 12 hours. This says 12 plus, but it should say more than 12 hours. Then they refer to the new IRP or IMR, the independent medical review for that safety determination, and then it goes back to the plan. So our guess of how this will work for MLTC is that you request a conflict-free assessment just as you do now. And the initial assessment, the nurse assessment will determine your eligibility for MLTC. And if you are determined eligible, Maximus will then go ahead and refer you to the IPP for that practitioner panel. Will the plan still do an enrollment visit? We don't know. We just don't know. And will they still tell the consumer how many hours they're likely to approve? I don't know. But you'll still enroll the same way you do now. So there's a lot we don't know yet. Big concerns are delays. I mean, scheduling all these assessments will create huge delays. And what's the immediate need process? If it's now taking 2 months to schedule a nurse assessment for a conflict-free assessment, how will you ever get immediate need? The deadline is that they have to authorize services within 12 days after the application is filed. And the state has been referring any complaints about delays and conflict-free, say you should go apply for immediate need. But if immediate need has to request these same independent assessments, it's going to take forever. Now, when we raise concerns about these delays, the state put in the regulations that the DSS or the plan may authorize a temporary care plan of more than 12 hours a day, pending that high need independent review panel. if they can't meet the deadlines. So for one thing, even if they do this is late in the day. You've already gone through the delays in scheduling the IA, then the IPP. Scheduling the independent review panel is the least of your problems. So this can only be scheduled, after those have been done. Once the plan decides you need 24-hour care, and they can authorize that 24-hour care as a temporary care plan. But the reg doesn't require the plan to do it. It just says they may do it. So we really the consumer has no way to enforce that, since the regulation says it's optional. And then, as I said, there's added delays if the plan disputes a material fact in the independent assessment. There's all these page numbers here. These refer to the reg as posted by the state, and the link to that is on the beginning slide of this section. But now these regs are final, so if you go into Westlaw or Lexis or wherever you look at regulations, they have all the changes now. Now, the state didn't put deadlines in for all this to happen, but they did say that plans still have to comply with federal deadlines if a client requests a new service or an increase in services. So those deadlines, even the standard deadline is 14 calendar days from the receipt of the request. And that's subject to an extension of another 14 days. So maximum 28 days. Even that seems like a tough lift if it's taking 2 months to schedule a nurse assessment, right? Let alone all the other assessments. But a consumer can ask for an expedited request from a plan. And that, by federal regulation, has to be done within 72 hours after the receipt, subject to 14 days. So there's really just no way that they can meet these deadlines. Big concern about this March 1st rollout is there's no guidance yet. The only thing there are the regulations, which are really bare bones. I'm giving you what there basically is in the regs. It doesn't answer a lot of questions. There's no administrative directive or MLTC policy. There has not been a public webinar. There's no FAQs. And that's still true today as of January 26th. And there are huge operational issues that every local district, every plan, every MLTC has to set up and train their staff and do internal procedures. There is some guidance issued, which you should look at. These were issued in December, directives about some of the new regulations, but they don't touch on the independent assessor. The only things they talk about are that now reassessments are annual, not every 6 months. There are some changes affecting CDPAP in terms of responsibility of the designated rep. They now have to be present at all assessments. The CDPAP consumer is limited to 1 fiscal intermediary. There are some changes in the CDPAP agreements. And now the one good change is that an M11Q or physician's order may now be signed by a nurse practitioner or a physician's assistant or an osteopath, not just an MD. And that is now in effect. So for your immediate need requests or other requests where you need the M11Q or physician's order, keep this in mind, and you can cite this guidance in your cover letter so that the DSS will accept it or the plan will accept it. There are some other changes, but they're really not very significant. They're not these major changes. So as I've talked about, we have real concerns that New York Medicaid Choice does not have capacity to do this. they don't have the nurses. Do they have, and what we've heard is they're poaching nurses from the plans and offering bonuses to come to New York Medicaid Choice. So that's nice, except that the plans now don't have enough nurses. And so, and there's a nursing shortage anyway, aggravated by COVID. So why is the state doing this at a time where every nurse is a precious, has this precious role, and they shouldn't be making them compete? They need staff to do all these independent reviews and the call center. I mean, just that. We know that there have been capacity issues in the call center. When people call in to request a conflict-free assessment, it goes to voicemail and they don't have a return call. We were told that they have now instituted some better callback system, but I don't know that that has the capacity for all these new assessments. And we asked the state, well, how are these all going to be set up? And they said by a phone call. So that's 300,000 at least new phone calls a year. So for example, they said for these the renewals, the annual renewals for 280,000 people in MLTC and MAP, on a staggered basis over the year, Maximus will send a letter to every MLTC member saying, okay, if you're up for renewal, give us a call. We're going to set up an independent assessment. So give us a call. So that's 20,000 extra calls a month they're getting. Do they have that capacity? As I said before, another concern is that, you know, whoever they're hiring, they're not people who know the consumer. I mean, sometimes an MLTC plan will have the same nurse assess the consumer year in, year out. They get to know them. And that's just not going to happen anymore. We know that there were still problems with these assessments, and then the fact that there's no more M11Q or physician's order, there is no opportunity for the treating physician to write a letter, you know, unless we will still, of course, do that when we're requesting an increase or you're requesting services, but there's no systematic way to do it. So one tip I'm suggesting is that we all just have to get in the habit of getting a letter of medical necessity or asking a doctor even to fill out the M11Q or for the physician's order form, just using that form to give to the nurse when they do the independent assessment and give to the physician when they're doing this IPP. And make sure that they hear what the physician says about the consumer's needs. Now, appeals and fair hearing rights. I mean, there are certainly concerns on this, and you know, one of the things we raised was, well, if this, let's say, a very common scenario is that the plan authorizes, you know, say 8 hours a day, even though the consumer requested 24-hour care. So if the regulations now require that you have to have gone through that independent medical review, the high need assessment, will an ALJ even be able to order that at a fair hearing? Because the judge might say, well, wait a minute, you didn't have an independent review panel. And the consumer says, yeah, because I wasn't allowed to make that referral. The plan decided I only need 8 hours a day, so they didn't refer it for that panel. But I've been asking for 24-hour care the entire time. So at a meeting, the state said their intent is that, yes, a judge will be able to say, all right, the plan didn't forward it, but the consumer has made a case that they have proved they need 24-hour care. But we can just see problems with this, right? Some judges will say, well, you know, it has to be made crystal clear in guidance that has not been issued yet. And a plan is not allowed to even put in 24-hour care unless there was this independent review panel. But the regulation does give an exception to that and says if a fair hearing orders it, or a judge, you know, a judicial court of a court says so. But they didn't list that if there was a decision on external appeal from the Department of Financial Services. So we have asked them to clarify that of course that has to control, because that's the state insurance law. What will be in the evidence packet? I mean, obviously we think all of this stuff needs to be in the evidence packet, including any assessments that the plan thinks had a factual error, and all the correspondence about that, because all of that is relevant to the case. Will New York Medicaid Choice be a party to the hearing? You know, it's their nurse, their doctors, their nurse practitioners who are doing all these assessments. So the plan, who's going to get these all together to give to the consumer? And can the consumer cross-examine these witnesses at the hearing? So lots of questions about this. The biggest question is, are you for real that this is happening March 1st? You know, how can that be? They just haven't postponed it yet. We have suggested, well, why don't you phase this in? You know, start with maybe just DSS and not MLTC. Start in one county. Start with only the initial MLTC enrollment, since those go through a conflict-free assessment anyway. If that's the least of a big lift compared to everything else. Radio silence, we don't hear anything. You can read NYLAG's Medicaid Matters letter listing a lot of these suggestions. That's also one of your handouts. CLE code 1. If you're doing this for CLE credit, code 1 is the word January, capitalized, with a 2 at the end, no space. So it's capital January 2, the digit 2, no space. All right, one more time, January 2. All right, so Peter, should I pause to just take a question or two about the independent assessment?
Yeah, there are a couple that I honestly don't know how to answer, but
right.
Mostly because I've been trying to keep up myself. But okay, so there was a question that I answered, but you might as well clarify. The independent assessment is equivalent to the conflict-free evaluation, it seems. Is that a fair statement? In the sense that it's the same?
It's the same instrument, it's the same nurse from New York Medicaid Choice, right? So that hasn't really, but the role that assessment plays, that very assessment will now be used by the plan or the local district as their nurse assessment. So it does double duty. It replaces a separate assessment by the plan. But it is still the same assessment. It's the same document that they use now.
Okay, and the independent assessor and the independent, it says independent practitioner. I think they mean independent, the panel, for everyone, including people who are grandfathered.
Yes, good question. The only grandfathering is going to prevent that referral for that third assessment, that independent medical review, or sometimes they call it independent review panel, for people who need 24-hour care or more than 12 hours. The grandfathering does not help in terms of, you still have the independent assessment and you still have the independent practitioner panel. And those will be done every year on renewal. Those will be done every time you request an increase. They require both.
So then grandfathering really just protects them as this is rolled out, not at reassessment.
Well, the grandfathering is only about that. They don't have to do that one assessment, that high need review. There's no grandfathering that saves someone from having to go through the independent practitioner panel.
Okay. This one I don't think it's about the IA, so we can come back to it later.
Okay.
Oh, there is this one. Are there going to be independent assessor clinics for folks to go to for an independent assessment?
No, these are, look, the UAS takes about 3 hours to do for one person. So no, I mean, these are individual. If you've ever been to a conflict-free assessment or a nurse's assessment, you know that, I mean, these take a few hours to do, and there's a one-on-one assessment. So no, there's no clinics.
Okay, would the changes that you just discussed affect PACE programs?
Good question. You know what? I don't know offhand. We'll try to find that out. I don't think so, but I'm not sure. Great question.
Okay, I think you just answered this, but the clinics question, the person who asked this asked a similar, well, not a similar question, but an overlapping question about the physician form. Sorry, let me find that one. What makes us think that DOH will use the 4359 for the physician's order? This form will be very difficult for a physician to fill out for a patient who they only met once.
Well, they said that at some meeting. That's why I think that they plan to use that form. You know, we had one meeting with them about this and had the opportunity to ask some questions, and that was one. All right, I think I'm going to move on, but Peter, just keep, you know, we'll have time at the end, and we are going to make up for the time. So let's plan on this going to 11:30. If you can't and you need CLE credit and you can't take that time, I'll send Peter a message and I'll announce the code early, before 11:15. All right, now we want to go into some other things that are now in effect. And this is a very big one that is a little subtle, so we want you to understand it so that you can spot the issue in your cases. And this is a change that affects people who changed MLTC plans or involuntarily were required to enroll in a plan and previously received home care. Okay, so I'll explain what that means. So let's say someone got home care through immediate need, or they were in a plan like an MLTC plan that closed. So in those situations, they were required to enroll in an MLTC plan or change plans, right? If your plan closed, you have to change plans. So when they change plans, they have transition rights, sometimes called continuity of care rights. And what that means is that the new plan has to give the same plan of care, meaning the same hours of home care, the same types of home care, the same types of other services and amounts. Sometimes they have to even keep the same providers, but the state is not requiring that anymore in MLTC. And how long is that transition period? It's generally 90 days, but there is one situation where it's 120 days. And that is if the MLTC plan closed, and that's why the consumer had to change plans. So that's what transition rights are. And this part of the PowerPoint is summarized in a fact sheet, which you have as a handout and is also available for download. So again, transition rights apply if an old plan closed, and there's a whole MLTC policy about that in the footnote. They apply if you've received immediate need, and then after 120 days, you were required to enroll in an MLTC plan, but caution on that, big caution. After 120 days, New York Medicaid Choice sends immediate need recipients a letter saying, you are now required to enroll in a plan. If you don't pick one, we will enroll you in Happy Acres MLTC plan on May 1st. People should not enroll in a plan before they get that letter, because otherwise they won't have these transition rights. And we hear that sometimes they are sort of pressured to do it because their home care agency says, oh, if you want to keep the aid you have, you need to join one of these 3 plans that we contract with. That might be true, but it doesn't mean they have to do it now. They need to wait till they get that letter. Otherwise, they will not have these transition rights. So it's very, very important to wait. Okay, so if you help someone get immediate need, this is part of your job to counsel them on that. Another situation where transition rights apply is if they had Medicaid before they were enrolled in Medicare. And so generally they were in a mainstream Medicaid managed care plan. These are the plans that most people who work with seniors don't really know about, because anyone on Medicare is generally not eligible for those plans. Except during the pandemic, people have stayed in the plan, so it's gotten confusing. But generally, if you get Medicare because you age in or because of disability, you're switched to an MLTC plan or a Medicaid Advantage Plus plan. And there you have transition rights, all right? Now, some of that's going on even now during the pandemic under a new procedure called default enrollment, and you'll want to read all about that in this article. A fourth situation where there are transition rights is if you were involuntarily disenrolled from an MLTC plan. And we'll talk about what the grounds are for those. But in most of those cases, you're assigned to a different plan. So in all of these situations, for 90 days in the new plan, it must continue the same plan of care you had from the old plan or from immediate need. The big question is what happens after that transition period is over, whether it's 90 days or 120 days. And this is what is changing under the regulation that went into effect November 8th. So the rule before November 8th was that a plan could only reduce hours for good cause, and those reasons are listed in this MLTC policy 1606, which if you do this work, you have to download that and have that in your key document folder. because it's a really important policy that applies to any time a plan is trying to reduce hours. And it limits reductions to situations where a plan can prove that the client's medical condition improved to the extent that it reduces their need for help, or their social circumstances changed. Again, reducing their need for help, such as if a daughter retired, has moved in, and is happy to help 3 days a week, and the client is also happy with that. Informal care always has to be voluntary by both the client and the caregiver. Or a mistake was made in the original authorization. And we know that that sounds like an exception that can swallow the rule, but it's defined in 1606 very, very narrowly. Now, up till November 8th, these reasons applied anytime a plan wanted to reduce hours, whether or not that person had transferred to that plan. So it applies just, even if, we see plans trying to reduce hours even to their own members who they've had for years, right? This policy applies there. But it also always applied if the plan got a transfer of someone from immediate need or from a closing plan. Effective November 8th, the state regulation now says that after a transition period, a plan can reduce hours if they claim that the DSS or the previous plan authorized more services than are medically necessary, without proving any change. The notice simply has to review the client's specific clinical data and medical condition and indicate a clinical rationale, which, in our experience is sort of a lot of blah, blah, really, because we see a lot of clinical data listed in these notices, right? We see they list data, they just don't make a logical conclusion from the data, right? We see them, you are bedbound, you are quadriplegic, you are incontinent, you do not need an increase from 6 hours a day of home care. So from this, that would be fine because they show they'd reviewed the client's situation. And that would be okay for a reduction. So it's important to note that they are not throwing out policy 1606. All of these reasons are still required for most reductions. These are only reductions after a transition period ends. But in your intake of a client, if someone comes to you saying that my hours were cut, you will now really need to add questions to probe, did any of these situations apply? Because the client might not tell you this, because this may have happened three or 4 months ago. And they might not think it's relevant that they had immediate need and then transferred in. So they might not volunteer this in your interview. So you need to ask, when did you enroll in this plan? Did you get home care before you enrolled? And, all of these questions, okay? And then you'll know that this is what's going on. And what are you going to do? You are going to request a plan appeal. The notice still needs to be a reduction notice because even the state acknowledges that this is still a reduction. And with reductions come very important rights. You can request a plan appeal. If that's denied, you get a final adverse determination, and you can request a fair hearing. You have to do them very quickly within only 10 days of the date of the notices to get aid continuing. That is key. So if you're a social worker and making a referral to ICANN or to NYLAG, please take the steps first.
request the plan appeal, request the fair hearing, because there's so little time to do it. And then an advocate can represent the client on those appeals. But there's so little time to do it that we don't want that to get clogged up in an intake and then miss the key time limit for a plan appeal. And there's a fact sheet on plan appeals, link at the bottom. So just a reminder, this is what these notices look like. The initial adverse determination, they are a little misleading because there's a date right towards the top. It says you can ask for a plan appeal within 60 days of this notice. So that's the first date someone sees who reads the notice. If they read down farther, if you want to keep your services the same, you have to ask for it within 10 days. So that's a little buried, but that's the aid continuing deadline. And the FAD looks the same. So these are, all right. I will announce the code just before 11:15 when we said that this would end. Okay, second CLE code. So use the notices come with a plan appeal form. Use those because they have a fax number on them, and fax is the best way to lock in and prove that you requested the appeal. You have a fax confirmation cover, and you know, same thing for a fair hearing. So these are some slides on fair hearings I'm going to skip. But I want to contrast, we just talked about if someone involuntarily changes plans and changes in those transition rights. But now I want to talk about voluntary changes in plans, because sometimes a client will say, this plan's only giving me 6 hours a day, I want to change plans. Or the client will say, my AIDS agency is no longer contracting with Good Times MLTC. They're telling me to change to Sunny Acres MLTC. So I'm going to do that. So those are voluntary plan changes. And there's a change now that you can no longer change MLTC plans anytime. After you enroll in a plan, you have a 90-day grace period where you can change plans for any reason. After that, there's 9 months of lock-in where you can only change plans for good cause. And there is guidance on this, so you can find all the links at these links. So if someone enrolled before December 1st, 2020, they are not locked in because there's 250,000 people getting care, right? Many of them have been in plans for a long time. So they can change plans anytime, but once they do, there will be this 90-day grace period, and then they'll be locked in for 9 months. Now, this only applies to MLTC. This does not apply to PACE or Medicaid Advantage Plus. New York Medicaid Choice sends out an end of lock-in notice 60 days before the end of the lock-in period. So what is good cause? Good cause to change plans during that 9-month period is moving to a different county where the plan does not do business, the plan fails to furnish services, the member said, I only interviewed with this plan, I didn't consent, I didn't sign an enrollment form. The plan and the member can mutually agree that a transfer is appropriate, and an aide is no longer working with the current plan. But just because you can change plans, is it a good idea? No. And here's the guidance. There are no transition rights if you change plans for any of these reasons, even if you have good cause. Even though even what's really makes me angry, even if the plan has failed to furnish services, and that's why you're changing. It's considered voluntary, and you have no transition rights, so the plan is not required to continue the same plan of care of the former plan. So this is especially of concern to people getting high hours, right? If you're only getting 20 hours a week, this is not as much of a concern, because hopefully that won't be hard to get from another plan. But if you're getting 24/7, that's going to be very hard to get from a new plan. And the worst thing is, it's not even considered a reduction. The new plan doesn't even have to give you notice of reduction with aid continuing rights. They can just say, this is what we're authorizing. You're a new member. It's an initial approval. You can appeal because, or you can request an increase in appeal, but you have no right to added hours until you win those. Okay. So I mentioned before that one of the times that you have transition rights is in involuntary disenrollments. So let's just review these quickly. There are grounds for disenrollment. Disenrollments were suspended during the pandemic. The state just banned them. And they are now allowing them to resume on certain grounds. The grounds that they are resuming is a long-term nursing home stay. We're probably not going to have time to go through that. That's if you're in a nursing home for more than 3 months and you've been approved for institutional Medicaid. So there are a number of slides on that in this presentation. And there are protections that you want to look at. If you moved out of the plan service area within New York State, you hopefully should get moved to a different plan. MAP plans have a quirky disenrollment because they are a hybrid plan. They include a Medicare Advantage plan called a dual SNP or dual special needs plan. So in order to be in that MAP plan, you have to be in that insurance company's dual SNP. And lo and behold, the annual enrollment period comes for Part D, people get marketed to. We had a client who said, oh, I want to be in Humana. I'm changing plans. Well, guess what? They were disenrolled from their MAP plan because they had to be in the Health First MAP plan, dual SNP, to be in their MAP plan, and their home care is disrupted. So you want to pay special attention to people to figure out if they're in a MAP plan. Look at these lists of plans to figure out, are they in a MAP plan or not? So for if they move, they move out of the service area, actually, the gist says that they will not be assigned to an MLTC plan. They'll be referred to the local district to give fee-for-service plan pending a reassessment. So that sounds like you're asking for trouble. It sounds like there's going to be disruption there. You're going to have to be proactive. And that also raises issues about Luberto moves from county to county. They have also just very recently, December 2021 GIS, have reinstated disenrollments for bad behavior. So if that behavior is result of the member's diagnosis, they're not supposed to disenroll you for that, because that would violate ADA rules. But there are fair hearing rights on those notices. And they just reinstated this one if you were absent from the service area for more than 30 days and 90 days for Medicaid Advantage Plus, then you can be disenrolled. So, but because of COVID, many people paused their home care. And the state allowed that. This guidance came out in April 2020 saying people can put their home care on pause. They want to limit their own exposure to COVID. They don't want AIDS in the home. Their family lost their jobs, they were laid off. They can take care of the member. So, but now that's over. And now if you're absent from the service area for 30 days, you can be disenrolled. So what we think should happen there is that New York Medicaid Choice will notify the member that they can transfer to another plan. So first, the plan sends a member a 30-day notice of intent to disenroll, and that does not have appeal rights. Then they refer it to New York Medicaid Choice, which sends a member a 10-day notice of enrollment, and that does have fair hearing rights and aid continuing rights. So with the exception of moving to a different county, which I said they should be assigned to a new MLTC plan after disenrollment and have those transition rights for 90 days. So then that new regulation will kick in for them. All right, before I get to this, I'm going to announce the code. So the CLE code 2 is capital word winter. The season winter capitalized, then numeral 6, no space. All right, we're just going to take a few minutes to talk about the thing that might be coming down the pike. If CMS, well, we heard that CMS approved it, but it's on hold because of the public health emergency, because the state's not allowed to reduce eligibility for services during the pandemic. So this is the new minimum needs requirement. In order to even get MLTC or personal care, you'll need 3 ADLs. And with those, you'll need what they call limited assistance with physical maneuvering with the ADLs. The only time you can qualify if you need cueing or supervision is if you have dementia or Alzheimer's disease, and then you can qualify with 2 ADLs. And the list of ADLs, they said they're using the list in the UAS assessment, which includes walking or locomotion, bathing, personal hygiene, dressing, eating, toileting, and incontinence care, and transfer on and off the toilet. Medication administration doesn't count, nor do they list just general transfer in and out of bed or turning and positioning. So that's a big change from now. Now you only need 1 ADL to enroll in an MLTC or to get personal care from your local district or CDPAP. And now, even if you, let's say you go through the conflict-free assessment, but you fail it. The conflict-free assessment says even now, you don't have any ADL needs. So even now, you can go back to your local district and apply for something called housekeeping. So that's a very limited service. It's just 8 hours a week for people who don't have any ADL needs, but they do need help with housekeeping chores, laundry, shopping, cooking, cleaning. But this program is ending because housekeeping is a type of personal care. And if personal care now requires that you have 2 or 3 ADLs, if you don't have any ADLs, you don't get personal care, so there's no housekeeping. So there's at least 1,000 people around the state getting housekeeping. I mean, it's not a huge program, but this is really going to burden some of you, Suffolk County Office for the Aging, those of you who run ISAP programs and help people get into ISAP, which is a state-funded only home care program that already has waiting lists. this is really going to add to their waiting list because all these people will now go to ISET. We don't know when this is happening because it won't happen until the end of the pandemic when it's declared over. On this, some people will be grandfathered in, okay? Anyone who qualifies for personal care or consumer directed and is receiving it, or at least authorized for it at the time this is implemented, will be grandfathered in. And anyone who's getting housekeeping at the time this starts will continue receiving housekeeping, but they won't have anybody new get housekeeping. So this shows you, this is sort of like a screenshot of the UAS where the nurse grades each ADL on a scale from 1 to 7, from independent to total dependence. And this shows you that where you'll need to land to get 3 ADLs is the need for limited assistance, guided maneuvering of limbs, physical guidance without taking weight. Now, and that's the step higher than supervision, which is oversight and cueing. So I think now a big point of advocacy and a role will be preparing clients for the interviews for immediate need or for MLTC and say, let's sit down and let's just look at which ADLs do we think you need limited assistance for. And you're going to have to make a case at that independent assessment to say, look, we think she needs these 4 ADLs and hope that you get 3. But supervision and oversight and cueing will only count with the dementia diagnosis. They won't count for someone who needs supervision because of a traumatic brain injury or a developmental disability or because they have a visual impairment or other neurological or psychiatric impairments, which is, you know, pretty much, it seems to be purely discrimination based on diagnosis, which violates Medicaid regulations and probably the ADA. So we think there are big questions on this. The state even was sort of embarrassed by their sister agency, the Office of Mental Health, actually submitted comments to the regulations. And they said, what about people with serious mental illness? They need cueing assistance. They're not going to qualify for personal care. So because another state agency raised that, the state said, oh, whoops, our bad. We will set up a procedure for people with serious mental illness to request an exemption as a reasonable accommodation. But they didn't even add it in the reg. It's just going to be some other procedure that no one will know about, except hopefully all of you. It's really, and of all people to have to go through an extra procedure to request an exemption, serious mental illness, doesn't make any sense. So, you know, we've always had concern about when people say my client needs safety monitoring or supervision, because that is always sort of rings alarm bells, because a court decision way back over 20 years ago said personal care doesn't include just standalone supervision or safety monitoring. It just doesn't include it. It only includes this cueing and supervision to assure safe completion of an ADL. So at least with the dementia case, you want to always be sure to say, my client needs cueing or supervision with these 2 ADLs, all right? But it won't help you to qualify unless the client has dementia. All right. So we are at, I think I'm going to leave these slides for you to read on your own and take some questions. If you're not on our email list, you can sign up at this link. Here are, there's a resource sheet. And all right. So Peter, let's see about any other questions.
Sure, and I don't know if you can hear this, but it sounds like someone is drilling for oil outside of my building. So.
Oh, I can't hear it.
Okay, good. Okay, so, well, there was one question earlier. When someone is transitioning to managed care, they get the letter that gives a deadline date to join a plan. It is then safe to enroll in a plan, right? This is the notice from Maximus saying you have to join a plan by X date. That should trigger transition rights.
Right. You know, I am not sure about the timing of that. Do they wait 120 days till they send that? I think they do. It should be okay, but I just don't see any reason to jump the gun. Like if they say, those notices say, we are enrolling you on March 1st. And so pick March 1st. Like why enroll earlier? It's probably okay if you get that notice in January to enroll for February. But, you know, take a calendar, make sure they were receiving the immediate needs services for 120 days. I'm reluctant to say it's fine without really knowing the timeline.
Okay, and
just be really careful.
A COVID-related question: do consumers no longer have the ability to pause their home care? Is that still in effect?
You know, that is such a good question. They never revoked that guidance. You know, I'm just going to show you. They did revoke other guidance, but on home care, they've revoked. So if you look on our website, you always can look at COVID resources, and so if you click right on the home care policies, you see they've rescinded a lot of guidance. Look at that. Rescind. But the guidance for voluntary schedule change was never rescinded. That guidance that rescinds a lot of guidance did not rescind this. So to me, it seems to still be in effect, but they're treating it as if it's been rescinded. But I think you should try it if that's your situation. You know, talk to the plan and say, look. But they've now put in the ground for disenrollment to be if you are absent from from the service plan for 30 days. So it seems to me you could only pause it absent for the service area. Okay, so that doesn't say you just decline services for a few weeks. So if you're not leaving the service area, it seems you can still do that. But this ground is now in effect. So I think they meant to revoke it, and I think they just haven't.
Okay, and since you're there, 2 slides down on the 3 ADL requirement.
Yeah.
Someone asked, and maybe this was some confusion about the way the slide is written, but I thought you can't. It's the part about ISEP. I thought one can't get ISEP if they are Medicaid eligible.
Well, I think it's a great point, and I think that will have to be changed to be not only you're Medicaid eligible, but eligible for Medicaid home care, right? I mean, because it used to be that if you were eligible for Medicaid home care, you were eligible for ISEP and vice versa, because they did have this program. But with this program ending, I think that they're going to have to change that. But that's a very good point, and I think that's going to need advocacy.
Okay,
Very
and
good.
a procedural question for, or maybe strategy is the right word. If you're appealing a denial for an increase request, who will be the respondents after March 1st? Is it the IA, the MLTC, or both? Who would you send a letter of medical necessity to support the need for an increase on appeal?
Okay, so it's still your plan or your DSS making all decisions. So you'd always want to send a letter of medical necessity. You're requesting the increase from the plan. You're advocating with them. But that said, you'll also want to give it to the independent assessor at the time they assess you. And I don't know how you're going to do that with telehealth, honestly. These are other issues. But because you'll want the nurse and the independent practitioner panel to take into consideration what your doctor says in that letter, because that will then influence the assessment, which will be used by the plan or the DSS to determine your need. So, and I guess so the answer is everybody. But it's still the plan making the decisions. And it's still the plan or the DSS whose decisions you are appealing. It's not, except in that situation of where the conflict-free assessment. If Maximus says you don't, if you don't meet these new ADL criteria, that appeal will still be against Maximus, because that will still be done by the nurse in the independent assessment. So that's just how it is now too.
For the 2 ADLs for the dementia patients, will proof that a dementia will you need to prove there's a dementia diagnosis?
Yeah, that's somewhere in the reg. That's a great question. I'm pretty sure the regulation says something about that. Yeah, I mean, yeah, you're going. Look, I mean, what's proof? You know, a doctor saying that you have the diagnosis, right? I mean, I don't think you need to show that the brain scan, but because these diagnoses are often clinical, right? Just based on behavior and history. But look, I don't know. That's a great question. But that will probably be something that's, and look, there are different types of dementia. There's different causes of dementia. So it's not only Alzheimer's disease, but it still leaves out so many other cognitive causes of impairment that are not dementia. So, but you're right. You've spotted an issue that will probably require some documentation.
And this one is, well, it says, can you explain why you think CMS has approved the ADL changes? But I think that's really why does DOH think that these changes are permissible? I haven't seen documentation of this anywhere.
Right. Okay. So that's a great question. This goes to my theory of invisible ink. So there's something called a state plan amendment that the state had to submit for, that's a state plan amendment of the state's Medicaid plan. because this is a change that doesn't only affect MLTC, it affects all services, right? So all services, their sort of criteria are all in the state Medicaid plan. And the state submitted those, and we had an opportunity to comment, and we did. And then the state, I'm not going to find the links right now because it's just too hard to navigate in the webinar. But the feds then did approve the SPA amendment. But there was no mention of SPA being the state plan amendment, with no mention. So if you look here, I just clicked on comments. Here is NYLAG submitted comments to the state's proposed amendment of the new ADL criteria. So that you see the proposal. And when you go to the proposal, well, what I should do is, you know what, I will post here the final amendment that was approved, and you'll see that it doesn't mention it. These are all on the state's website. It's easy to find on the state's website. But I'll post a link here. It doesn't mention it. So we've raised this, right? What we were told is there was a colloquy between CMS and DOH where CMS said, you know what, if the state just changes criteria for a service, that's up to the state. We don't need to have that in the state plan amendment. It's just not required. So the state said, okay, so we'll just take that out. And the plan amendment was approved without it. And the state told us it was approved. And the way we found out is we looked at the approval and we said, we don't see it. Where is it approved? And so I said, well, is there any communication about this? Something in writing to say it's not required? He said, you can submit a Freedom of Information request, which I did back in July. Now, 6-7 months later, there's no response. And that's our state's open government. So we hear it was approved. And again, the way you get here is just in this article. There's always, if you go to our homepage in the news, there's always New York State Medicaid, because I put all updates here. So you can always click on the new independent assessor procedures. And I may not have posted that, but a lot of it's here. Okay. So that's the answer. There's no answer, but the feds reportedly are just allowing it without a state plan amendment.
Okay. I think 2 more. Is that?
Okay.
This one, I think the answer is no, but I am not sure. So, and I think, okay, there is a deadline of the 20th of the month to have the current assessments completed so services can be implemented by the 1st of the following month. I think that the person writing this means plan enrollment. Does the IA process change any of that or no?
I don't believe so. I believe that all comes from the state's computer system, how much time it needs to, hook up a member into a plan, database. So, and have payment go to the plan, which is all, triggered by these coding changes that come from enrollment. So no, none of that will change. That will still be the same deadline.
Okay, and then will the assessment be required for home care reinstatement at discharge, presumably from an inpatient facility? as opposed to a new request for coverage.
So the regulations list both. The regulations list both of the IA and the IPP, the nurse and the physicians have to be done at any request for an increase and upon any nursing home discharge and upon any hospital discharge. That's what it says, which is another big opportunity for delay.
Okay, there's a number of other questions. Some of them I'm not sure if, I mean, one of them is based on a rumored RFO process. I don't know about, so I'm not even sure if I.
For managed care plans?
The question is, how will the rumored RFO by Department of Health for MLTC impact the whole process?
Okay, well, it's not a rumor. It's in the state budget proposal. That there is a proposal to have plans go through some kind of procedure where only like 5 will be selected in a region. Something I haven't focused on that. So it would whittle down the number of plans. Both managed care and MLTC. So especially in New York City, where there's something like 20 plans now. But I haven't read it closely, and I don't know. It looks like they want to, just like they've reduced the number of LICSAs, they've reduced the number of fiscal intermediaries. Every contract is work for the Department of Health to administer, so it seems like they want to just reduce that workload generated by having so many plans to monitor and audit and contract with. So it sounds like it's an opportunity to get rid of some of the smaller plans, and that they will be sort of gobbled up by the big plans. But again, I haven't looked at it closely.
I only said 2 and I got 3 out of you, so I don't know if you want to stop.
Okay.
There are others.
All right. So, we will review other questions. You'll get an email if there's anything that we didn't cover. We hope to be able to post this if someone can figure out how to splice out all the dead time of the delays. And thank you for your patience and for all of our technical difficulties, which were worse than normal. And thanks for participating. We'll schedule another one, if we do get news. But if we also get news, we'll send out an e-blast. So there's that slide if you're not in our newsletter to sign up for our newsletter. And thank you. I'm going to end the webinar now. Thank you.